So good evening, everyone. My name is Isabel Germano. We are now live streaming on YouTube, and I am the chair of the AANS CNS section on tumors. And tonight I am very happy to be here with our faculty who decided to share with you why they are program directors of a neurosurgical oncology program. Dr. Annalise Rodriguez is the co-chair of education for the tumor section, and she will be moderating this seminar. The format is pretty straightforward. Each of the three presenters will present for 10, 12 minutes. And then at the end, we will check the questions that you might have, and you can write them in the chat. And also possibly Dr. Rodriguez and myself will ask questions to our panelists. Annalise? I think you're still muted.
Thank you, Dr. Germana. Well, thank you everyone for coming tonight. And also this is obviously being live streamed and will actually be up on YouTube shortly after. We have three great programs to feature tonight, Emory, Pittsburgh, and MD Anderson. And we wanted to highlight the tumor section. I was really invested in an educational series for career development. And we wanted to highlight some of the great past programs and also show the diversity that we have in terms of region and some of the opportunities that are unique to each program. So to get started, we'll go ahead with Dr. Holm from Emory, and she'll talk about their oncology fellowship.
Great. Thank you, Annalise. I appreciate it. Let me get my slides up. 1 second. All right. Well, I'm from Emory over in Atlanta, and I'll just give a couple slides about what our fellowship is like. And I put all of our contact information. You guys can see everything well, right? Okay, great. Contact information for the fellowship. So please feel free to reach out if you have any questions after tonight. So let me make this. Okay. So we have been CAST accredited for our Emory Fellowship in Neurosurgical Oncology since 2009. And like probably all the other fellowships that are being featured, we have about a 50-50 split of either internal or external applicants, and that has borne out in the fellows that we take. So, our residents are eligible, of course, to do the fellowship. And so they, about half the time they end up taking our fellowship spot. And then we also take a significant number of external applicants outside of Emory after they have, of course, finished nowadays at least their chief year or 6 years of residency is the official rule. As is true with all the programs that are on featured tonight, just like Pittsburgh and MD Anderson, Emory is not a place that usually has any issues with volume. So as we all know, there are minimums that we have to complete when we're in fellowship as far as cases and our case logs. And so very luckily, our fellows have never had any issue with that. But we do offer a wide variety, as you might expect, of cases and surgical opportunities, depending on what you potentially might need for your job in the future. And that includes things like complex skull base, of course, radiation, both SRS and LINAC based modalities. All the things that you need for neurosurgical oncology, awake, sleep mapping, functional mapping, all that kind of stuff. And even spinal oncology, if that's your particular interest, particularly if you might be going into that practice or even a more private-demic sort of practice. And we have a diversity of techniques since all of us trained at pretty different places. We also give you exposure to some of the newer things like fluorescence, which are important in our field, things like brachytherapy, which is brand new, and laser interstitial thermal therapy, so that you can, if you'd like, incorporate that into your practice. And I know everyone feels very differently about those things. And we are a place that has very traditionally for a long time had many fellows, not just in tumor, but in a wide variety of other subspecialties at Emory. So there's a clear expectation for how you interact with the residents. At most of your cases, you will have either a PGY2 or a chief or both. There's luckily, because the residents are very familiar with having fellows and we set clear expectations, there's no issues with sort of interpersonal things, which certainly can happen when sometimes residents are not as familiar with working with fellows. And so that's just an unfortunate thing that you don't want to have to deal with when you're trying to learn. We technically cover 5 sites across Atlanta as a practice, or as our total group. But you as a fellow will be mostly at our main campus location at Clifton, and occasionally covering at Midtown. And our skull-based faculty are now over at Midtown. So those are your 2 main sites. We have a very multidisciplinary focus, as you might imagine. We have weekly tumor board, weekly truly multidisciplinary clinic. So we are all co-located together with the radiation oncologist, the radiologist, and the neuro-oncologist all together, so we can make quick decisions and our patients can see everyone at the same time. So it's very helpful when you're trying to think about setting up your practice. We have clinical trial management group, which we call our monthly neuro-oncology working group, which you participate in. And then, of course, we are part of the Winship Cancer Institute, so we have a wide variety of resources from that standpoint as well for any work you want to do. Sort of the nuts and bolts, for our program, it is a year long. You're in the OR on most weeks. And of course, you're an adult, so you decide what's going to be best for your learning. And we really encourage that because obviously, you know best the holes in your education and what you're going to go to fellowship to learn. And so we are not very regimented in, forcing you to do certain things, as long as there's good justification. That is the benefit of having one fellow. So usually most fellows do 2 to 3 OR days per week. We definitely want you to do 1 clinic day, again, in that multidisciplinary clinic. And then we usually say that you're welcome to have 1 admin job search day, research day, a week if you need that. Job search is a big part of what you do during your fellowship, potentially. You do take full attending call when you're in our fellowship, and that's about 3 to 4 days a month. And this is real attending call. This is, I think, excellent for fellows to be able to be comfortable as they transition to being an attending. It's nerve-wracking, and being able to take that real, on your own call, knowing that you can call one of the tumor faculty if things, get overwhelming is really, really nice. And so you take general call, and then if there's anything that is elective, you redistribute that in the morning or at the end of the weekend. So never stress, you're never left alone. And obviously, I just like to say that Atlanta, which is where our fellowship is a very easy place to live, no matter if you are single or you have a family. We've had fellows with, multiple kids who need to be relocated for a year and go to school. So it's very, very easy to do. This is our faculty. We have, intra-axial folks, skull-based folks, and I think probably a lot of those people. And then we also actually have Dr. Dibert, who is over at a more private site at St. Joe's, but is absolutely excellent in gamma knife SRS. And so a lot of our fellows take advantage of that, depending on, again, what they want to do for their ultimate practice. And then, a lot of folks ask about, what opportunities there are for research and education, things outside of the OR and what I've already mentioned. Emory's a large institution. You have lots of opportunities. I'll just highlight a couple of things. We have a really robust infrastructure now over the past 4 or 5 years for clinical outcomes, research to get publications and submit abstracts for conference to answer your clinical questions. You do not have to, reinvent the wheel or anything like that. There's a whole 2 actually registries that I run that are set up for this purpose through the Cancer Center and through the Brain Tumor Group. We actually had one of our fellows do a Master's of Science for clinical research during his time. And then another fellow actually used some of the work he did from a registry standpoint to set him up for a NCI, MSCR, essentially, when he went not to be a first-year attending. So great clinical opportunities given the overall caseload volume you have to do during the year. We also have had some fellows very involved with clinical trials. We have this very good, well-established clinical trials office. They help, and so it's easy for you to really see how that might incorporate into your academic practice for anything from trial design, drafting the protocols, the paperwork side of things, patient enrollment. It's really how involved you want to be. So some fellows have been very, very involved with that. Of course, there's always translational and basic opportunities. That's really up to you and your prior research interests. Again, there's a lot of cases in clinical volume, so you have to really think that up. That's something you'd want to do. Some of our prior fellows have taken advantage of our genomic data for this. And then, we're very, generally as a group, we try to stay involved in organized neurosurgery, obviously. And so we really encourage our fellows and try to give them opportunities. We sponsor our fellows to do those kinds of things, such as presenting at meetings, being involved in committees where we may have a role, and then Dr. Olson, one of our faculty, is obviously, if you know, is a huge part of the guidelines. So many of our fellows have actually participated in, working on the guidelines, which is a great experience to have. I just think it's good to know where our everyone ends up. And so our goal as faculty, we think one of our biggest roles is placing our mentees at their desired job if they are after a fellow that comes after residency, or if they're an enfolded fellow, then getting them to the right fellowship. And so for each year I just showed where all of our fellows have ended up eventually, and again about 50-50 split, either as a very academic job or as a job where you may be the girl or guy who does pretty much all of the complex tumor work. And so the fellowships are very important. Down at the bottom, you can come to our website and you can see that generally, if you would like to apply, usually about a year and a half before your entry date, which is standard, I think, for most programs, we just ask for 3 letters of recommendation and a CV, some basic info. And usually I do a Zoom meeting with anyone who's interested before we even have our formal interviews, just to make sure that we will be a good, to set expectations and to make sure no one's wasting their time through the interview, and to kind of really, answer any questions up front about the fellowship. So happy to talk with anyone about that. I think that's all in my slides.
Thank you so much. That was a great overview. So we'll go ahead to the next program, and we'll save questions to the end after everyone has presented. And we will go to Dr. Raza from MD Anderson next to talk about their program.
Thank you so much for having me and giving us an opportunity to present the MD Anderson program. I'm the fellowship director here, and I just borrowed some slides from the presentation I normally give to our applicants to give you an overview. Just a little bit of our department. Really, we have a department of 14 faculty that's really focused on the entire spectrum of neurosurgical oncology. And in terms of where education and the fellowship really fits into our mission, it really is an important arm of our mission, because there's only so much work that we can do individually. And so that's why we put so much effort into training our fellows so they can go on and do great things and really improve outcomes for patients after they leave Anderson. And on the right is our department motto. And this is the tree of neurosurgical oncology, where each of the major branches represents some of the major subspecialties in neurosurgical oncology, such as spine, brain, skull base. But really at the heart of that is really research and data. And that's sort of how we really have structured the fellowship. As I mentioned, in terms of the team, we have 14 clinical faculty. And I think what's great about the fellowship is the opportunity to work with full-time clinicians, innovative surgeons, physician scientists, and there are all sorts of academic role models within the department that the fellows get to interact with. And while working with 14 faculty can seem daunting, where, matter of fact, given the degree of subspecialization, we're actually broken down into 3 different teams. And as a fellow, you essentially rotate through the 3 different teams, which I'll cover in a little bit. When I look at the objectives of a fellowship for the neurosurgical oncology program at Anderson, when the fellowship was started in the early 90s, so much of the fellowship really revolved around surgical technique. The idea of mapping was new. The idea of doing simply an orbital was new. And we know that the job requirements to be a neurosurgical oncologist have evolved over time, where not only are there new techniques that one has to master, but also understanding the bigger picture in terms of disease biology, multimodality therapy, and really putting all those pieces together so you can serve as a leader of a larger tumor board. And that's really how we've structured the fellowship, where the expectations of our fellows is not only do they understand surgery and they spend a lot of time in the operating room, but understanding newly diagnosed and recurrent disease. And this is a fellowship that's not only focused on glioblastomas, but really the full spectrum of CNS, skull-based spine pathology. Heavy emphasis on multimodality therapy, not only in the day-to-day through working in tumor boards and in clinic, but also the academic side of things and working with the neuro-oncologists and the radiation oncologists. And then, on the research side, we certainly offer a 2-year track where a fellow could do 1 year of laboratory and translational research before going into the clinical fellowship. But even for those that do the 1-year fellowship with us, everybody's put through a clinical trial design course, which I'll highlight in a little bit. And then a heavy emphasis in terms of ensuring that our fellows really have the educational skill set and the administrative skill set to really run an oncology practice, given sort of the modern landscape. Now, in terms of the day-to-day on the clinical service, as I mentioned, given the degree of subspecialization in our department, our overall department is really broken down into a cranial service, a skull-based pituitary service, and a spine service, and you can see the attendings listed there. And for the neurosurgical oncology fellows, what we do is they ultimately spend 4 months on each service. So they really get mini fellowships with the intraaxial surgeons, the skull-based surgeons, and the spine surgeons. And what's great is while working with 14 faculty can seem daunting, with these mini fellowships, I think the fellows really develop close relationships with the attendings and really spend time in the OR and the clinic with each one of these attendings. Now, again, reflective of sort of the evolving sort of demands of being a neurosurgical oncologist, what we also added was a dedicated radiosurgery experience. So prior to adding this rotation, certainly the fellows were getting a good amount of radiosurgery experience on a day-to-day basis, and certainly by attending the tumor boards in terms of decision-making. But what we wanted to do is really get them a crash course with regards to radiosurgery and interacting with the radiation oncologist. And it's more than simply framing, but understanding planning and the radiation dosing. And so we've added that to the experience. Now we have 3 neurosurgical oncology fellows, and then we have 1 dedicated skull-based fellow. And then on top of the 4 fellows, we have a variety of residents that come over from other programs. And ultimately, the fellowship is designed where you spend a majority of time in the operating room and then clinic at least 1 day a week, and then certainly academic time on top of that. In terms of clinical technology, everything that I think you would expect from a neurosurgical department, everything from an intraop MRI, or matter of fact, building a brand new IMRI suite, minimally invasive endoscopic suites. What's rare for cancer centers to have a hybrid endovascular suite. We have that also, and of course the full complement of intraoperative adjuncts such as 5-ALA, lit, endoscopes, exoscopes, and so forth. Now, these are the working conferences that the fellows participate in. As you go through each one of the cranial, skull-based, and spine rotations, you essentially participate in the tumor boards appropriate for that rotation. What's common is that to all the rotations is the entire department gets together every Monday to review the upcoming surgical cases. And then otherwise, for those fellows rotating on the cranial service, they participate in the CNS tumor board and the Friday SRS conference. Those fellows that are on the skull-based service participate in the skull-based tumor board, and then the separate spine tumor board, and then of course the pituitary tumor board. And these are all working conferences. As I mentioned, our fellows that participate in the 1-year fellowship also, from the research standpoint, participate in our clinical trials design course. And this is a 4-day course that's run in conjunction with the other surgical oncology fellowships at MD Anderson, and is taught by surgeons and statisticians at MD Anderson that actually have experience with clinical trial design. And essentially all our fellows participate in this, and the objectives by the end of the 4-day course, each fellow leaves with a clinical trial sort of protocol draft ready to go. And they essentially have sort of mentorship throughout this process. And I think this has been a nice addition to the academic training that our fellowship provides. Now, certainly there's a lot that I think the fellows learn just by showing up every day and participating in clinic and participating in the tumor boards. But then we also realize that it's important to add on didactic conferences to fill in those gaps and provide that fund of knowledge that they may not get on a day-to-day basis. And so we have a pretty robust didactic curriculum that happens on a weekly basis. Most notably is this monthly clinical neuroscience series that happens in conjunction with the neuro-oncologists and radiation oncologists, where essentially it's a case-based discussion with the fellows where we go through some of the practical considerations in terms of managing newly diagnosed and recurrent disease. And each month a particular diagnosis is picked. So by the end of the year, really, the neurosurgery, neuro-oncology, and the radiation oncology fellows really understand the bigger picture in terms of multimodality care. In terms of our experience with fellows and where they end up, since the fellowship was started in early '90, we've trained nearly actually 104 fellows that have graduated from the program. And in terms of a split, about 72% have ended up in academics, and the remaining in private practice with subspecialty practice in cranial care. And what's great with having such a long history of fellows is that we actually learn a lot from the fellows. That once they go out into practice, we stay in touch with them, and we learn a lot from their experience. And we've used that feedback to sort of fine tune our fellowship over the years to make sure that we're relevant to what the job market wants out of graduates coming from fellowship. And these are our current fellows. 3 neurosurgical oncology fellows from Cornell, Columbia, and Harvard MGH, and then our skull-based fellow from Iowa. And, at least in this picture, they seem very happy, and we try to keep them happy during the course of the year here. So in terms of wrapping up, in terms of what we're looking for is really, we're looking for fellows that want to be part of this and that really want to understand not only the full spectrum of surgery, but multimodality care, and really to get that in-depth experience to skull-based, cranial, and spine, and to really move the needle forward in terms of making things better for our patients. And, certainly, contact information there in terms of the application process. So once again, thank you very much for having me.
Thank you so much. That was also a wonderful overview. Our last speaker for tonight is Dr. Hajipanias from University of Pittsburgh, and he's going to review their program and opportunities.
Okay, let me get this up here. Sorry. Okay, can you see this? Let me put this on. All right, well, thanks everybody for inviting our group to present here on our brand new Neurosurgical Oncology Fellowship. We just started it this year. We're excited to report we have our first fellow who's busy in the fellowship. I hope she's on tonight. Anyhow, so, you heard really some great presentations from some top-notch neurosurgical oncology fellowships. And, we are kind of new in terms of the fellowship, but we're actually kind of old to the game in terms of caseloads and innovation and technology. I mean, University of Pittsburgh has a number of firsts that I'm really happy to highlight in terms of really bringing the Gamma Knife to the U.S. with over 18,500 cases completed since 1987. The origins of endoscopic and nasal approach really came from Pitt in the 90s and has really blossomed into almost a standard of care approach for many of the skull-based tumors that we perform surgery on. We've done over 4,500 endoscopic and nasal cases. First intraoperative imaging suite in the U.S. and, operate on over 700 primary and brain metastasis tumors a year. Technology and innovation, I think, as you heard, is really important to the fellowship. And learning about some of the newer techniques and pushing the envelope with some of the stuff that we do, I think, is very important. And our fellowship, is really designed around those latest technologies. So the fellows leave the program very well prepared with a variety of technologies, including fluorescence-guided surgery, the exoscope, the Gamma Knife, LIT, endoscopy, and we'll get into that a little bit more. The experience really involves 2 of our main hospitals. So UPMC Presbyterian Hospital is our main hub where the residency is at and the medical school is at, but our UPMC Shadyside Hospital has kind of evolved into our cancer hospital, and it's only 1.5 miles away. And that's also a full-service hospital, but we have a total of 9 neurosurgical oncology faculty that participate in the fellowship, and we treat, all primary brain tumors, brain metastases, meningiomas, I didn't list it here, skull-based and spinal tumors. And we have a world-class monitoring group called ProCirca as part of our department, which monitors all over the country, actually. And they're integral to what we do in terms of mapping, awake procedures, of course, fluorescence-guided surgery, epilepsy tumor surgeries, and one of the highlights of the fellowship. And our fellows actually spent some time learning Gamma Knife, since, it's a pretty Gamma Knife heavy program, and also exposed to LINAC radiosurgery if they wish as well. Understanding, use of LIT. We have LIT at both of our campuses at UPMC Presbyterian Hospital and Shadyside Hospital. And in addition, the ROSA robot is something that we kind of introduced for our stereotactic biopsies with the exoscope and neuroendoscopy. Currently, our fellow has to, basically attend a half-day of brain tumor clinic. This is nice just so they can kind of follow the patients that they operate on. Because we have a number of faculty, it's not exactly an even exchange in terms of clinic, but, I think it's important for them to pre-op some of the patients and then see them in follow-up. They then have 1 to 2 days of operating at either campus, depending on cases, they want to be part of. And we have 4 residents in our program per year. So we obviously our residents are quite important in their training. So we have a very nice balance between the fellow and our residents. We also offer a half academic day for just, manuscript abstract preparation. Our group publishes about 20 manuscripts per year. And this fellow is going to be part of that this year. We have, some medical students and residents that also assist with that. Very large database, especially based on some of the Gamma knife work that's been done for decades here, that really has allowed us to compile some important manuscripts detailing some of the leading approaches for radiosurgery and other brain tumor treatments. The faculty are pretty different in terms of what they do. We have just hired a spinal oncology focused neurosurgeon, James Bailey, who's really gotten quite busy at our Shadyside campus. And then, we have these other faculty who are focusing on different technologies that are available through the program. This is, a busy program, but at the same time, I think it's important to focus on some of the academic parts to it, where, the fellow is really trying to, publish some things and learn some newer techniques and hopefully, present in our meetings. So I don't know if I have any other slides. I don't think I have any other slides. Happy to discuss it further with any particular, prospective applicant, provide more details. Happy to communicate by email. Thank you.
Thank you so much. So I know Dr. Germano will look through and see if there are any questions in the chat. I'm going to go ahead and just ask a question to you guys from one of our previous seminars. There is a lot of interest in, is there any formalized mentorship, and I just wanted to hear your thoughts on how mentorship works at each respective program.
I'll start. Let's go in our little order. So there's a formalized mentorship in the fact that we meet with our fellow. So as the director, I meet with the fellow every month to go over their case logs and their experience, their research projects, and their job. Obviously those are different priorities at different times during the year. But we definitely hit those major high points. And actually, we also have a formalized residency mentorship program too. So I kind of borrow some of that stuff from there. But obviously each one of the faculty in the program have different fortes as far as mentorship. And so depending on what the fellow's looking for, sometimes, Dr. Olson's better for certain things, or Dr. Endrum or Dr. Padilla or something like that. So it's definitely not all just with one person. And obviously we're very aware of that, but we do have a formalized component in that we meet once a month to go over our progress and make sure we're not falling behind on anything.
Along those lines, we've also adopted more of an active mentorship plan. So, as fellowship director, I meet with the fellows individually on a regular basis. And usually the conversations at the beginning of the year really revolve around, what the individual fellow wants to get out of the fellowship in terms of their objectives, along with, the academic project and their job hunt. And then as the year goes along with those regular meetings, there's more feedback that's incorporated. So looking for feedback from the fellow. And then we have formalized evaluations that the faculty fill out for the individual fellows at the end of the rotations. And so I provide that feedback in those individual meetings with the fellows so that they get that feedback as they go along. And then along those lines, since we have so many faculty, and ultimately the fellows will also pair up with one of the faculty based on sort of clinical and academic interests and subspecialty interests.
Yeah, I just want to add to that. I think just echo what everybody said, but having an open door policy where we can really make sure we communicate regularly about anything is important. I think all the attendings here are in tune with training the fellow and sensitive to their needs. I know the caseload mix has been changed recently, so that's something that we're trying to make sure we abide by. But I think overall, just, really stay in touch with them and really communicate with them and make sure that they're on track as well academically.
Thank you, Kostas. And there is a question that came through the WhatsApp. And that ties very well with your last sentences of the caseload change. And so the question revolved around, why are we talking about a CAST accredited fellowship as opposed to a generic neurosurgical oncology fellowship? So I will just share one slide here trying to answer that. The first slide I'm sharing is actually to thank the three of you tonight for sharing with us about your program. And Annalise, Brad could not make it, but both of you for having the idea and helping us put in these webinars together, because I think that sharing the knowledge about the programs is very important. So why CAST and what is CAST? So CAST is the Committee on Advanced Subspecialty Training. It resides within the Senior Society of Neurosurgery. And as you can see here, there are only a few programs in the United States that are CAST approved. And what does that mean? It means that those programs have to apply to the central organization, and their caseload has to be reviewed. And then also all the educational, mentoring, and other part of the fellowship components have to be approved. Dr. Ajapanayas referred to the caseload, and this is the last procedure of requirements that we approve. Within the tumor section, there is a CAST committee, and we send suggestion into the society, and the society is actually asking us to provide suggestions. And so what Dr. Ajapanayas was referring to is that we just divided the load of the fellow into intraaxial and extraaxial. As you can see, the number of cases is really not that much, but we wanted to set a bar that there is a minimum. And similar with radiosurgery, so on each of the three programs that were presented tonight, the fellow would do much more than that. And yet we wanted to set that bar so that everybody who comes out of a fellowship that is CAST approved has at least 150 cases. And you can see this at the bottom of the slide here. Now, in the non-CAST fellowships, and there are some that are not, and the institutions are not listed on this slide, you might or might not get that mix. You might not get that 150, and you might or might not get that dedication of the teaching and all the other components. So that's really, in a nutshell, what is the difference between a CAST approved and non-CAST approved fellowship. So I think that from the perspective of the consumer, you as the applicant, you're more protected if you apply to a CAST fellowship, because you know that this is under the supervision and the scrutiny of many neurosurgical oncologists that want nothing but the best out of that. That being said, there are also fantastic other programs that can provide great training. And so we should always keep an open mind about that.
Thank you. That was a great overview. And I will say for this is our second series, and we plan to have another one or two, but we are only featuring CAST fellowships. And again, it's just because of the amount of work that went behind making sure that you're going to get this really the breadth and depth of neurosurgical oncology. So there is. Yeah,
there are two more questions. You want to just briefly mention those? So one is asking the difference between a neurosurgical oncology and a skull-based fellowship. Those are very different because the requirement of cases is different. So the question is, neuro-oncology fellow also spend time rotating within the skull-based surgeon. That is absolutely correct. But remember that for the neurosurgical oncology, you have intraaxial and extraaxial. So you do both. And the emphasis is on the intraaxial, whereas for the skull-based, the requirements are all different subtypes of skull-based. And then the second question is, how many years in advance of starting the fellowship are residents expected to apply to the program? And Dr. Hong did touch on that, but I'm going to let each of the three speakers specify what is their requirement. Kim?
Yeah, so about 1.5 years before you plan to enter. So usually for a lot of people who are in a 7-year program, it's their 6th year is when they interview that fall time of their 6th year. Or if, again, you can adjust that depending on how you plan your fellowship.
We're the same also for a 7-year program. We accept applications in June of PGY 5-year. That's when the application website opens up. And then we interview in September of the PGY 6-year and offer acceptances then.
Yeah, very, very similar time frame. The earlier, the better we hear about people. I think now that we're new, we are offering it to our residents, but I anticipate opening this up to outside graduates very soon here.
And I wanted to ask a question about interviewing. Something that everyone is interested in is, what are you looking for? There's obviously going to be a big group of people. Oncology is a very popular subspecialty. Can you just speak about, what would set someone apart from the crowd, or what are unique characteristics you're looking for at your program or the culture of your program that would make someone kind of fit in?
Yeah, I think, we always look for is that the applicant has a clear idea what they're doing their fellowship for. Like they understand that they need to learn something or they want something out of their fellowship that's very specific and to help them, get to their next step for a job. And so if they can articulate that well, and then if we think that we can help them in a meaningful way, sometimes it's just not a good fit, then that's what we look for. And then, of course, I mentioned we have a very busy and strong resident cohort. And so we want to make sure someone who is a good team player, it sounds obvious, but, you'd be shocked. And we'll make sure that everyone works together. And we work really hard to make sure those expectations are set up front.
Essentially echoing the same points, really looking for fellows that can articulate, their career plan and how the fellowship really, contributes to that career plan. Also, I think from the clinical standpoint, we're looking for fellows that not only want to operate a lot, of course, but understand that the goal of the fellowship is to understand the decision-making, interact with the medical oncologist and the radiation oncologist. And then on the academic side, we often get asked, are we looking for physician scientists? What type of research phenotype are we looking for? And I'll say that I'm not a physician scientist. We look for a lot of diversity because ultimately we need all sorts of academic types to move the field forward. So we're not looking for any individual sort of phenotype on that end.
I think the point that Kim brought up is an important one. Functioning well with our existing resident structure is so important. I really stress that I want them to work together as a team. And, while the fellow has independence, they also have to learn to work with our chief resident, other residents. And, for example, today we had a very good case, and Justice Callos is our fellow, and she worked really well with our chief resident, a complicated parasagittal meningioma case, but it wasn't overpowering. She was there to help the chief resident. And that's kind of what we're looking for. We're looking for team players, have energy and, really want to work well with the residents. Super important.
I'll check in with Dr. Germano because we're getting close to our time. If there are any more questions in the chat.
No, I think we covered them all. And thank you again, everyone, for being with us tonight, and Annalise for envisioning this and executing it to perfection. It's really nice, I think, for our group to share our passion and to share the opportunities to train the people that perhaps want to do what we're doing.
Yes, thank you so much for your support, Dr. Germano, for this series, and hopefully we'll be back in January. And thank you for the 3 of you to taking out time from your very busy clinical schedules. And we'll be sure to advertise that this is going to be posted online.
Thanks so much.
Thanks for having us.
Thank you.
Good night, everyone.
Thank you. Bye.
Bye-bye.
Bye.